Hi everyone, welcome to Tony's tutorial, and today we are going to discuss something from the hip biomechanics, that is the ligaments of hip complex. Now when I tell you the ligaments of hip complex, something that you might think would be like, oh, why should I study the ligaments? It's not much important, it's just anatomy part. There are just few structures. Why should I study? But I want to tell you, if you want to excel well in your clinical practice, either as a doctor or a physiotherapist or a chiropractor, learn ligaments in depth, because they contribute such a great role to the stability, and as well as a great role in providing restriction to the mobility. So you cannot treat a patient well if you are unable to understand which ligament is involved, which ligament might get injured in this activity, etc. So learn the ligaments with greater interest, and here we are going to crack it in one of the simplest manner, but of course in depth itself. Okay, so let us start the ligaments of hip complex. The first thing that should come to your mind is the fibrous capsule. The fibrous capsule, or the capsule of hip joint, or hip joint capsule. The first thing that you must think. So what do you mean by a capsule? You might have seen the capsules like omeprazole tablets, which comes in as a capsule, and inside that you have the medicine. So you open the capsule, you get the medicine. Similarly, something that covers the joint like this. So if this is a capsule, you open it, you get the joint, you see the joint. So something that has a similar function is the capsule. For example, let us see in this hip joint how the capsule acts. Okay, so look at my three fingers, the first finger, middle finger and ring finger. Three fingers. This is how a capsule runs about. It runs completely into the joint. It covers the intra-articular surfaces completely. So articular surface become intracapsular actually. Not just anteriorly, but in the posterior aspect too. So that is the capsule. So what is the peculiarities of hip joint capsule? Let us start. It is a covering for the joint, okay? That is the simple point. It's a covering for hip joint surfaces, okay? Now, one of the most important thing is that when you consider the shoulder joint or the glenohumeral joint, what differentiates between the hip joint and shoulder joint is, in hip joint, the capsule contributes substantially to the stability of the joint. And the capsule is highly strong. The capsule is strong capsule. It contributes substantially or highly to the stability of the joint. So that's the two important thing that you should remember. It is a strong capsule and it contributes substantially to the stability of the joint, comparing or differentiating itself from glenohumeral joint or any other joint. Now, what are its attachments? Okay, attachments. Let us see it. Here, when I showed the hip complex or hip joint, you see here we have the acetabulum. So this starts from the rim of the acetabulum. This starts from the, if I open my index finger, that's showing the opening. That starts from the rim of the acetabulum and attaches to the intertrochanteric crest. From rim of the acetabulum to the intertrochanteric crest. Posteriorly, if you see, posteriorly, it is from the rim of the acetabulum, but up to the intertrochanteric crest. Exactly speaking, 1 centimeter medial to the intertrochanteric crest. Exactly speaking, not until the intertrochanteric crest, but 1 centimeter medial to the intertrochanteric crest. So it is simple. It originates from a rim of acetabulum, and to anteriorly it is attached to intertrochanteric line. Posteriorly, it is attached to 1 centimeter medial to intertrochanteric crest. Here it is crest, okay? 1 centimeter medial to intertrochanteric crest. So that's attachment of hip joint capsule. Now, what are the features of hip joint capsule? Features. Yes, the features. The features. Yes. If you evaluate the hip joint capsule, you can see 3 peculiar structures. One is longitudinal fibers. The other one is oblique fibers. The last one is capsular ligaments. Ligaments thickened. So if you open up the capsule, you can see the longitudinal fibers, oblique fibers and capsular fibers. Longitudinal fibers means these are the fibers that runs longitudinally. Oblique fibers means there are some fibers that runs obliquely. And like any other joint capsule, there are some capsular ligaments which reinforces the ligament, the capsule. So the capsule of the hip joint is made up of longitudinal fibers, it is made up of oblique fibers, and it is also made up of capsular ligaments which are thickened, and we see them as thickened structures. Now the longitudinal fibers, what are the features? The longitudinal fibers, they are numerous in number. So they are numerous in number. They are in the outer space. They are in the outer space or outer fibers. Outer fibers. They are attached to the periosteum. Attached to periosteum of bones. So if we evaluate the longitudinal fibers, we see that they are numerous in number, large in number. They are attached to the periosteum of the bone, both bones, okay, and they are seen in the outer fibers, or they are the outer fibers. Inside that you have the oblique fibers. So the first fibers is longitudinal. They are numerous in number. They are seen outer and they are attached to the periosteum. Now let us see the oblique fibers. The oblique fibers, they are lesser in number. Okay, this is larger in number, so this is lesser in number. There is innermost fibers, okay, and at the neck of the femur, these oblique fibers differentiate to form a collar-like structure. See, you have here the neck of the femur. Let me draw it for you. Just imagine this is the neck of the femur, okay, and you have the acetabulum over here. So we have our capsular ligament, capsule attached like this, capsule attached longitudinal and oblique fibers. And what happens is that at the neck of the femur, these oblique fibers arrange themselves like a collar around the neck. These fibers arrange like a collar around the neck, and that structure is known as zona orbicularis. Zona orbicularis. Zona orbicularis are region in the neck of the femur where the oblique fibers differentiate into a collar-like structure. So what is the function? It helps to prevent the distraction of the head. See, let my fingers be the collar. If it is attached like this, can I distract the head of the femur? I cannot. So that is the function of this zona orbicularis. So I want to show you something important here, that is the zona orbicularis. So let us summarize again. The longitudinal fibers we discussed about that. They are numerous in number. They are the outermost fibers, and then we had the oblique fibers, which we had to discuss like they are lesser in number. Then they are the innermost fibers, and something that is important over here, at the neck of the femur, they forms the zona orbicularis, which is a specialized differentiation of the fibers. This is a specialized differentiation of the fibers, and the function, do not forget, it helps in the prevent the distraction. What are the other features of the fibrous capsule? It is thick anterosuperiorly. Thick anterosuperiorly. Thick and strong anterosuperiorly. You know that anterosuperior region, this is the anterosuperior region. Okay, here is the maximum body contact that is occurring. The weight can transmit from the lunate surface. We saw that superior portion of the acetabulum, superior portion of the head of the femur receives the weight. So this surface has more friction, more chance of stress, and the articulation is relatively less because this comes deep into it, but this surface is not. So here what happens, the capsule has a greater role because this inadequacy or this insufficiency is being reinforced by the capsule. So the capsule is thick anterosuperiorly. So if it is thick anterosuperiorly, anybody can tell it is weak postero-inferiorly. So you studied 2 points very easily. It is weak antero-inferiorly. Now the neck of the femur is intracapsular. Neck is intracapsular. I will explain it. Let me note down it. Neck of the femur is intracapsular. The greater trochanter is extracapsular. Lesser trochanter is also extracapsular. Okay, let me show you. When I showed the diagram, when I showed like this with my fingers, always my fingers has to work. You see the neck of the femur, you cannot see the neck of the femur. This has been covered by the capsule. So we call it as intracapsular. Inside the capsule, intracapsular. But the greater trochanter is outside the capsule, that is extracapsular. The lesser trochanter is outside the capsule, that is also extracapsular. So neck of the capsule is intracapsular, greater trochanter is extracapsular, lesser trochanter is extracapsular. Why do we study like this? We have a clinical importance. That is why we are discussing it in detail. I will tell you that. Before that, then there are some fibers known as retinacular fibers which travels through the capsule. These retinacular fibers travels inside through the capsule. What is its function? They transmit the blood vessels. So there are some fibers known as retinacular fibers that travels beneath the capsule or through the capsule to the neck of the femur, that transmit the blood vessels for nourishment of the head of the femur. So that transmit the blood vessels that are important for the nourishment of head of the femur. Okay, so you have here retinacular fibers that transmit blood vessels for head and neck, of the femur. You have retinacular fibers that transmit blood vessels for head and neck of the femur. Okay, these retinacular fibers origin from medial and lateral circumflex artery. If you need, only just remember it, otherwise just forget that, no need to worry much about it. Retinacular fibers you must remember. So the capsule of the hip joint has some retinacular fibers, and through the retinacular fibers the blood vessels are transmitted to the head and neck of the femur. So why did I went on blah 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 over here, intracapsular, extracapsular? That is because if you have a fracture of the neck of the femur, if the neck of the femur is fractured and the fracture is intracapsular, these retinacular fibers would go damaged. If the fracture is involving the neck but extracapsular, that is greater trochanter is not much affected, lesser trochanter is less affected, is spared. What happens is if the capsular fracture is extracapsular, the retinacular fibers are also saved. So here there won't be damage to the head of the femur. But here, if it is intracapsular, the damage to the blood vessels result in loss of nourishment to the head of the femur and can result in a condition known as avascular necrosis of the femur. Avascular necrosis of femur. So these are the important things that we must learn about the capsule. That is, it is thick anterosuperiorly and strong, weak postero-inferiorly. The neck of the capsule is intra-articular, femur is intra-articular, greater trochanter is extracapsular, lesser trochanter is extracapsular. There are some retinacular fibers that transmit the blood vessels to the head and neck, and they arise from medial and lateral circumflex artery. And if there is a damage to the retinacular fibers, that during the fracture of the intracapsular neck fracture, it can result in a condition known as avascular necrosis of the femur. That is all about the capsule of hip complex. So the first ligament or the first structure known as the fibrous capsule is over. The second structure is the ligamentum teres. Ligamentum teres. Before that, just have a quick refreshment of ligamentum teres. The second one is ligamentum teres, or it is also known as ligament of head of femur. Ligament of head of femur, or round ligament. Round ligament. So three names: ligamentum teres, ligament of the head of femur, and round ligament. Earlier, when we started to discuss this chapter, we saw there is a ligament that starts from the fovea and attaches to the acetabular notch. There was a ligament that transmits from the fovea to the acetabular notch, and that ligament is the ligamentum teres, or ligament of head of the femur. This is the head of the femur and its ligament, so it is known as ligament of the head of the femur. The peculiarity is it is triangular in shape. Most of the things are triangular in shape. Since it's a triangle, it has an apex, it has a base, it has two borders. The apex is attached to fovea capitis, that is the fovea of the femur. The base is attached to transverse acetabular ligament. Base is attached to transverse acetabular ligament. And borders is attached to acetabular notch. Acetabular notch. So, ligament of the head of the femur, even though it is called a round ligament, is triangular in shape, and hence it's a triangular in shape. It has an apex which is attached to the fovea capitis, which is attached to the femur, the head of the femur, fovea, the structure, and the base is attached to the transverse acetabular ligament. Here in the notch, you have a ligament that is transmitting like this. That is known as transverse acetabular ligament. It is attached to the transverse acetabular ligament and then to the acetabular notch. And the margins are formed by the margins of the acetabular foramen. See the medial margin, posterior, medial margin, lateral margin. These margins of the acetabular notch forms the borders or the sides of the ligamentum teres. Now, earlier we used to think that the ligamentum teres had no significant role, and we used to forget about that. There is ligamentum teres because in some persons that's quite absent too. But later on the studies showed that in high intensity activities like high hip flexion activities, which is quite common in athletic activities, because we are not going to run or jump like this, okay? It's common in athletic activity. There is the chance of damage to the ligamentum teres. And when there is damage to the ligamentum teres, we went on to study and we found out that there is instability for medial rotation and lateral rotation. There is instability for medial rotation and lateral rotation when hip flexion is 90 degree. So when hip flexion is greater than 90 degree, if there is an imbalance or laxity of ligamentum teres, in ligament we call it laxity, medial rotation stability, lateral rotation stability would be affected. Not in the normal case, but in hip flexion greater than 90 degree, and that is more common in athletes. Maybe because it is only seen in hip flexion greater than 90 degree, we could not study it in early times. Not because that people used to run at that time, people used to go for long jump now and then. That doesn't matter. So earlier we used to think there was no role for ligamentum teres, but now we understood that ligamentum teres has a great significant role, and that role is in high intensity hip flexion activity, that too greater than 90 degree. And when activity is greater than 90 degree, if ligamentum teres is weak, it can result in laxity of medial and lateral rotation. And one more thing that we have noted is, in athletes who have the laxity of the ligamentum teres, if we ask them to go for the deep squat position, you cannot see me, the deep squat position, there is a clicking sound. Click. there is a clicking sound or cracking sound and a pain. So that shows the laxity of the ligamentum teres. Or if ligamentum teres is damaged, if the person or the patient goes for deep squat activities, he finds a clacking sound and a pain. That is because in deep squat activities, the head and acetabulum can come much closer and all the structures can get compressed. So that time, what can happen, there can be a clicking sound, See, like this, the person is going for normal flexion to deep squat activities. That is also hip flexion. In deep squat, you are going for hip flexion, right? Okay, don't get confused. And that is also hip flexion activity. The patient can get, or the person can get, what you call this problem. Okay, and that is all about the ligamentum teres. Okay, so the ligamentum teres is also known as round ligament in the head of the femur. It has triangular in shape. It is attached to the fovea capitis and to the what? Acetabular nodes or transverse acetabular ligament and borders to the acetabular nodes. The primary function is above 90 degree of hip flexion. There has a role in restricting medial rotation and lateral rotation. If there is damage, this activity will be restricted in case of patients with the ligamentum teres damage. Clear? And the third ligament is the capsular ligaments. Earlier we used to, just before discussing this ligamentum teres, we saw capsular ligaments. So the capsular ligaments, there are three capsular ligaments. The first one, it is Illiofemoral ligament. Don't worry, I will tell you easy manner. Ischiofemoral ligament. And third one, it is Pubofemoral ligament. So three capsular ligaments. You know that you have ilium, pubis, and ischium. These are the parts. So if there is a ligament starting from the ilium to the femur, that is Illiofemoral ligament. If there is a ligament starting from ischium to the femur, it is known as Ischiofemoral. If there is a ligament starting from pubis to the femur, that is Pubofemoral ligament. So three parts for the hip bone, three ligaments: Illiofemoral, Ischiofemoral and Pubofemoral ligaments. Cool? Yes. So we are going to discuss the first one, that is Illiofemoral ligament. I should say this is one of the strongest ligament in the body. And of course, if it is strongest in the body, it is strongest in the hip complex also. Strongest ligament. It is fan shaped and inverted Y-like. Okay, since it is inverted Y, it is known as Y ligament of Bigelow. So the points are, this is the strongest ligament, it is fan shaped, it is an inverted Y-like, and since it is an inverted Y-like, it is known as Y ligament of Bigelow. Clear? Okay, now you want to know the attachments of the ligament. Where it is ilium, it starts from one particular location in ilium, that is anterior inferior iliac spine, and is attached to intertrochanteric line. Clear? Okay, so this ligament starts from the anterior inferior iliac spine to the intertrochanteric line, anterior inferior line iliac spine to intertrochanteric line. So it provides the anterior stability. It provides anterior stability to the hip complex. So when you are standing like this, you don't fall back like this. There is a significant role for the illiofemoral ligament. So illiofemoral ligament helps in preventing falling back. So the role or the function is helps in preventing trunk falling back. In stance. Now the major function is restraint to lateral rotation in flexion and neutral position. So what is the function of iliofemoral ligament? One is that it helps in preventing the falling of like this. The second one, it helps in preventing, see, this is the ligament attached like this. So it will prevent the lateral rotation from occurring. It will prevent or it will act like a restraint to excessive lateral rotation when hip is in flexion and in neutral position. Clear? That's all about the iliofemoral ligament. Let me summarize. It is the largest, the strongest ligament. It is inverted Y shape and hence it is known as Y ligament of Bigelow. It is the strongest ligament. It is attached from ilium, that is the anterior inferior iliac spine of the ilium, to the intertrochanteric line, and the major function is it acts as a restraint to lateral rotation when hip is in flexion or neutral position. It will prevent the backing off. That is the first one, that is the iliofemoral ligament. Second one, pubofemoral ligament. Pubofemoral ligament. Pubofemoral. What are the peculiarities of pubofemoral ligament? As the name suggests, from the pubis, that is from the iliopubic eminence. Iliopubic eminence, origin, obturator crest and obturator membrane. Obturator membrane. These are its origin. And inserted into neck of the femur, along with plus capsule, along with iliofemoral ligament. Iliofemoral ligament. I will explain to you later. Okay. And the function is lateral rotation restraint in extension. Okay. So just see the capsular ligament. Second one, pubofemoral ligament. Since it is from the pubis, it starts from iliopubic eminence, obturator crest and obturator membrane, and it is attached to the neck of the femur, but along with the neck into the capsule, because in neck you have the capsule, blends with the capsule, as well as to the continuation or the insertion of this ligament, iliofemoral ligament. So both the iliofemoral ligament comes and attached to like this, but the pubofemoral ligament from this part it goes and attached to the iliofemoral ligament. So if you draw a diagram, you have the acetabulum over here, you have the femur over here, you have the neck and intertrochanteric line, you will have this iliofemoral ligament like this, the inverted Y shaped ligament having two bands, exactly two bands like this, yes, exactly like this, yes, like this. And then you have below that or near to that the pubofemoral ligament, which arises from the pubic eminence here, and it is attached to capsule and along with the margin of iliofemoral ligament. That is all about the pubofemoral ligament. And the major function is this, since it is anterior, the other one is also anterior. So if that is providing restraint for lateral rotation, this cannot provide restraint for medial rotation. So both are anterior. So remember, both the ligaments are anterior. So both are providing restraint for lateral rotation. The other one is in hip flexion and neutral position. This is in hip extension. Cool. Yes. Simple points. You have to just remember it. And third one is ischiofemoral ligament. Ischiofemoral. What about ischiofemoral? It starts from ischium. Absolutely right. It starts from ischium and attaches to the greater trochanter. Some fibers into the greater trochanter, some fibers into the capsule and neck. So ischiofemoral means it's in the back side of the femur. It starts from the ischium and some attach to the neck, some attaches to the greater trochanter and some blends with the capsule. And the function is providing restraint for medial rotation. Since we have only one posterior ligament, whether the medial rotation is in hip flexion or extension or neutral position, this is the ligament that comes into action. So always restraint for medial rotation. That is all about the ischiofemoral ligament. So there we summarize the three capsular ligaments: illiofemoral, pubofemoral, ischiofemoral. Just remember the name: ilium, pubis and ischium origin. Function, both these are anterior, therefore restraint for lateral rotation. Only this is posterior, therefore restraint for medial rotation. Clear. Okay. And then we have the last ligament, which some textbooks do not give much detail about it, but I want to discuss it. That is a transverse acetabular ligament. Transverse acetabular ligament. Simple. We had discussed earlier. There is a ligament that runs like this. The acetabular notch. That ligament is known as transverse acetabular ligament. And earlier it was considered not to be a ligamentous in nature, but now it has some role. Especially it helps in the passage of blood vessels beneath. So this is having a gap over here, so the blood vessels can pass easily. So it is providing or protecting the blood vessels that are passing beneath, and it blends the margin or binds the margin of the acetabular notch. So that's all about the transverse acetabular ligament, not having much significant role. Just have to remember it spans the gap between acetabular notch. So we had to discuss the ligaments of hip complex, we discussed the fibrous capsule, we discussed the ligamentum teres, we discussed the capsular ligament, we discussed the transverse acetabular ligament. That's all about the ligaments of the hip complex, and we will wind up this session with discussing the clinical and applied. Okay, the first one is avascular necrosis. Avascular necrosis of femur, which we discussed earlier. If the fracture is intracapsular, if the neck of the femur is injured, retinacular fibers can undergo damage, and that can result in avascular necrosis of the femur. Second one, weight action in weight bearing or in stance phase. And stance phase, that is in normal standing. What happens is that the muscles are relatively inactive, because I had discussed in my biomechanics previous chapters. Body's role is conservation of energy. So muscles is relatively inactive in my stance phase. So in the stance phase, the line of the gravity is slight posterior to my hip joint. So when line of gravity passes posterior, there is an extension moment. We can go for extension. So this is prevented by the capsular structures, mainly the capsular ligaments. So we have to write in normal stance, line of gravity passes posteriorly, and it provides a gravitational extension moment. If this moment is unchecked, we may fall back, and that is checked by not by the muscles, but anterior capsule and ligaments. Anterior capsule and ligament. So in hip joint, there is a beautiful conservation of energy. That is in normal stance phase. If we are not going for any activities, there is a chance, since the gravitational moment is in the back side, we may fall back like this, and that is prevented by the anterior capsular ligamentous structures. That's all about the clinical aspects too, especially the avascular necrosis of the femur. And second one, what happens in stance phase. So if this, how it comes to clinical is, if a patient is having a laxity of the anterior capsular ligamentous structure, he can fall back. So if you are going for retraining the gait, you find that the trunk is unbalanced, but you check the abdominals, you check the core muscles, all are stabilized. But if these capsular ligamentous structures are weak, that can result in the posterior that is a trunk instability. So you must check that too. Okay. And finally, what is the closed back position of this joint? The closed back position of hip joint. The closed back position of hip joint is, see, this is the hip, okay? Slight extension with slight abduction and medial rotation. So the closed back position is this one. Extension with slight abduction and medial rotation. That is the closed back position of the hip joint. We can all try and do extension plus slight abduction and medial rotation. This is the closed back position. So if you all try, you move your leg to the extension, you move for slight abduction and medially rotate it. You feel that the complex is tight. That is the closed back position. Next one, most congruent position. So normally in every other joint, this both will be same. Closed back position will be the position of most congruency, maximum articular congruency. But in hip joint, that is not. There is a difference. The most congruent position is, you see, flexion with abduction and slight lateral rotation. The flexion with abduction and lateral rotation. See, the maximum congruency between the head of the femur happens. So in the maximum congruent position is flexion with slight flexion with abduction and lateral rotation. So the maximum congruent position is slight flexion plus abduction plus lateral rotation. This is cross back. This is most congruent. That is the most congruency. The bone is in maximum congruency. Here it is the cross back position. Everything is thick. Ligament, capsule, the synovial fluid, everything is a closed back nature. That is cross back. That is most congruent. Most weakened position. Most weak position or weakest position. Weakest position. Weakest position. See, the weakest position is the position where you cross your leg and sit. You sit in the chair, you cross your leg and sit. How do you cross your leg and sit? If you imagine like this, you are moving to the hip flexion and you are crossing your leg on the other leg. See, like this. Hip flexion with adduction. Hip flexion with adduction. So what happens? This is like this. So if there is a pull from this board like this, the head can dislocate back. This is mostly happening when you are sitting in the car, with this position, either cross leg or with the hip in flexion and medial rotation or adduction. When the leg can get hit in with the dashboard, especially in an accident, this hip can dislocate backward, the head can move backward. So that is the position of most weakest position. That is hip flexion with adduction. Example is cross leg sitting, cross leg sitting, or sit with leg over another, okay, that is a position. What happens is that you sit like this, the head can dislocate like this if there is a push from this side, okay. And most relaxing position, most comfortable position of the joint. You all of us may have the hip joint pain due to some, maybe we fall down, maybe there is an inflammation. What happens is, do we sit straight? Do we sleep straight? I don't think so. Do we sleep with the 90 degrees of hip flexion? No. But what we do is, we go for a slight hip flexion with abduction. That is, if a person is having a hip joint problem, he will slightly flex his hip and go for slight abduction. So this is a position in which all the structures in the joint are free. That is, the synovial fluid can move over another. Then there is an inflammation, there is increase in the synovial fluid. It can accommodate more level of synovial fluid, etc. This is what we do when we are sleeping. If you have a hip problem, we place a pillow underneath our knee so that the hip goes for slight flexion and abduction. And that position is very comfortable and the patients adopt. And similarly, most congruent position we need to know about the stability. And weakest position, of course, we know that we can avoid the chances of injuries and we can suspect and we can understand injuries if there is a problem with the joint. And most comfortable position is the position which persons or patients adapt when there is a problem or pain. So that's all about the ligaments of the hip complex. With a summary, a quick revision with the capsular ligament, then the ligamentum teres and the fibrous capsule. The capsular ligament include Illiofemoral, Pubofemoral, Ischiofemoral, and ligamentum teres. And finally, close back, close back, most weakened and most comfortable position. And two clinical importance, avascular necrosis and what are the function of the ligament. Anterior ligaments are the most strongest one. What is the function in mid-stand position? Thank you guys and stay tuned. Tomorrow we will be discussing about the torsion, anterior torsion, angle of torsion of the hip complex, especially anteversion and retroversion. It's a bit difficult to understand, but we will do it in the simplest manner itself. And the anatomy class, it's coming. So stay tuned. Please subscribe. Those who are not subscribed to my channel, Tony's tutorial. Thank you. Have a nice day.